Welcome to Pediatric Case Review. Today we will be discussing Charcot-Marie-Tooth disease in children, one of the most common inherited neurological disorders affecting pediatric patients. This presentation aims to provide a comprehensive overview for pediatricians and child neurologists to better recognize, diagnose, and manage this condition. Let's consider our first clinical case. A 7-year-old boy presents with progressive difficulty running and frequent tripping. His parents report he has been walking on his toes increasingly over the past year. Which finding is most consistent with Charcot-Marie-Tooth disease? A. Proximal muscle weakness. B. Foot drop and pes cavus. C. Joint hypermobility. D. Sensory symptoms preceding motor symptoms. The correct answer is B. Foot drop and pes cavus. These are hallmark early manifestations of Charcot-Marie-Tooth disease in children. The distal muscle weakness typically affects the peroneal muscles first, leading to foot drop, while the imbalance between stronger and weaker foot muscles gradually leads to the characteristic high arch deformity known as pes cavus. Our next case involves a 10-year-old girl diagnosed with Charcot-Marie-Tooth type 1A who is being followed in your clinic. Which pattern of progression would you most likely expect? A. Rapid deterioration within 1 to 2 years. B. Static symptoms without progression. C. Slow progression with increasing distal weakness. D. Primarily sensory progression with minimal motor involvement. The correct answer is C. Slow progression with increasing distal weakness. Charcot-Marie-Tooth type 1A typically progresses slowly over decades, not years. The weakness begins distally in the feet and gradually ascends to involve the hands, following a length-dependent pattern. While sensory symptoms are present, motor manifestations are typically more prominent and functionally limiting. Here we have an 18-month-old child with delayed motor milestones who has a father with Charcot-Marie-Tooth disease. What clinical feature would be least expected at this age? A. Delayed walking. B. Hypotonia. C. Pes cavus deformity. D. Decreased deep tendon reflexes. The correct answer is C. Pes cavus deformity. While infants and toddlers with Charcot-Marie-Tooth may present with delayed motor milestones, hypotonia, and decreased reflexes, the characteristic foot deformities like pes cavus typically develop later in childhood as muscle imbalance becomes more pronounced with growth and development. Foot deformities usually become evident between 5 and 15 years of age. Let's examine a 9-year-old with suspected Charcot-Marie-Tooth disease. Which finding would be most supportive of the diagnosis? A. Asymmetric weakness of proximal leg muscles. B. Inverted champagne bottle appearance of legs. C. Increased deep tendon reflexes. D. Prominent tremor and ataxia. The correct answer is B. Inverted champagne bottle appearance of legs. This distinctive physical finding results from the distal muscle atrophy affecting the lower legs, creating a thin appearance below the knees while the thighs remain normal. This is sometimes called stork leg appearance and is highly characteristic of Charcot-Marie-Tooth disease. The weakness is typically symmetric, reflexes are reduced or absent, and while some patients may have tremor, severe ataxia would be unusual. A 12-year-old with Charcot-Marie-Tooth type 1A presents with difficulty with fine motor skills. Which hand deformity would you most likely observe? A. Swan neck deformity. B. Intrinsic minus or claw hand deformity. C. Boutonniere deformity. D. Ulnar deviation of fingers. The correct answer is B. Intrinsic minus or claw hand deformity. As Charcot-Marie-Tooth disease progresses, the intrinsic hand muscles become weak, leading to this characteristic deformity with hyperextension at the metacarpophalangeal joints and flexion at the interphalangeal joints. This results in functional difficulties with fine motor tasks such as buttoning clothes, writing, or manipulating small objects. Which statement best describes the pathophysiology of the most common form of Charcot-Marie-Tooth disease in children? A. Autoimmune attack on peripheral nerves. B. Duplication of PMP22 gene causing demyelination. C. Acquired toxin-mediated axonal degeneration. D. Primary anterior horn cell degeneration. The correct answer is B. Duplication of PMP22 gene causing demyelination. Charcot-Marie-Tooth type 1A, which accounts for approximately 70% of all Charcot-Marie-Tooth cases, results from a duplication in chromosome 17p11.2 containing the peripheral myelin protein 22 gene. This leads to abnormal myelin formation, slowed nerve conduction velocities, and the clinical manifestations we observe. Which electrophysiological finding distinguishes Charcot-Marie-Tooth type 1 from Charcot-Marie-Tooth type 2? A. Charcot-Marie-Tooth type 1 shows normal nerve conduction velocity. B. Charcot-Marie-Tooth type 1 shows primarily demyelinating features with reduced nerve conduction velocity. C. Charcot-Marie-Tooth type 1 shows primarily axonal features with normal nerve conduction velocity. D. Charcot-Marie-Tooth type 1 and type 2 cannot be distinguished electrophysiologically. The correct answer is B. Charcot-Marie-Tooth type 1 shows primarily demyelinating features with reduced nerve conduction velocity. This is a key distinction between the major types of Charcot-Marie-Tooth disease. Type 1 forms are demyelinating neuropathies with significantly reduced nerve conduction velocities, typically below 38 meters per second in upper limbs, while type 2 forms are axonal neuropathies with normal or only slightly reduced conduction velocities. A 6-year-old presents with bilateral foot drop, absent ankle reflexes, and family history of neuropathy. What is the most appropriate first diagnostic test? A. Muscle biopsy. B. Nerve conduction studies and EMG. C. Whole exome sequencing. D. MRI of the spine. The correct answer is B. Nerve conduction studies and EMG. Electrodiagnostic studies are typically the first step in the evaluation of suspected Charcot-Marie-Tooth disease. They help determine whether the neuropathy is primarily demyelinating or axonal, which guides subsequent genetic testing. Nerve conduction studies in demyelinating forms will show markedly reduced conduction velocities, while axonal forms show reduced amplitudes with relatively preserved velocities. After confirming demyelinating features on nerve conduction studies in a child with suspected Charcot-Marie-Tooth disease, which genetic test would you order first? A. Testing for PM-P22 duplication, Charcot-Marie-Tooth type 1A. B. Complete Charcot-Marie-Tooth gene panel. C. Mitochondrial DNA testing. D. Whole genome sequencing. The correct answer is A. Testing for PM-P22 duplication, which causes Charcot-Marie-Tooth type 1A. Since this genetic abnormality accounts for approximately 70% of all Charcot-Marie-Tooth cases and about 90% of Charcot-Marie-Tooth type 1, it is the most cost-effective first test. If negative, broader testing with a complete Charcot-Marie-Tooth gene panel would be the next step, rather than proceeding directly to more expensive whole genome sequencing. A 10-year-old with Charcot-Marie-Tooth type 1A has increasing foot drop and frequent ankle sprains. Which intervention is most appropriate at this stage? A. Wheelchair for mobility. B. Ankle foot orthoses or AFOS. C. Pharmacological treatment with high-dose vitamin C. D. Nerve decompression surgery. The correct answer is B. Ankle foot orthoses or AFOS. These devices are a mainstay of Charcot-Marie-Tooth management, providing stability to the ankle and preventing foot drop during gait. They significantly reduce falls and ankle sprains while improving walking efficiency. A wheelchair would be overly restrictive at this stage. High-dose vitamin C has not shown benefit in clinical trials despite early promise, and nerve decompression is not a standard treatment for Charcot-Marie-Tooth disease. Which physical therapy intervention has the strongest evidence for benefit in children with Charcot-Marie-Tooth disease? A. Passive stretching of Achilles tendon. B. Resistance training for foot dorsiflexors. C. High-intensity aerobic exercise. D. Electrical stimulation of weak muscles. The correct answer is A. Passive stretching of Achilles tendon. Regular stretching programs have the strongest evidence for preventing contractures and maintaining range of motion in children with Charcot-Marie-Tooth disease. While moderate resistance training may be beneficial, excessive resistance training of already weak muscles remains controversial. Maintaining general fitness is important, but high-intensity exercise has not shown specific benefits and may potentially accelerate muscle fatigue in these patients. A 12-year-old with Charcot-Marie-Tooth has severe pes cavus causing pain and difficulty with bracing. What surgical approach would be most appropriate? A. Triple arthrodesis as initial procedure. B. Soft tissue procedures first, with osteotomies if needed. C. Tendon transfers alone. D. Observation until skeletal maturity. The correct answer is B. Soft tissue procedures first, with osteotomies if needed. The preferred surgical approach for pes cavus in children with Charcot-Marie-Tooth disease is to begin with less invasive soft tissue procedures like plantar fascia release and tendon transfers, progressing to corrective osteotomies if needed. Joint-limiting procedures like triple arthrodesis are typically reserved for older adolescents or adults due to their impact on growth and mobility. Observation alone would be inappropriate when the deformity is causing pain and limiting function. A 14-year-old with Charcot-Marie-Tooth reports increasing back pain. Which spinal complication is most commonly associated with Charcot-Marie-Tooth disease? A. Spinal stenosis. B. Scoliosis. C. Disc herniation. D. Spina bifida occulta. The correct answer is B. Scoliosis. Approximately 10 to 30% of children with Charcot-Marie-Tooth disease develop scoliosis, which is significantly higher than in the general population. This is thought to result from trunk muscle weakness and imbalance. Progressive scoliosis requires monitoring and may need orthotic management or surgical correction if severe. Other musculoskeletal complications include hip dysplasia and kyphosis. A 16-year-old with advanced Charcot-Marie-Tooth has nocturnal hypoventilation. Which respiratory finding is most likely present? A. Obstructive sleep apnea. B. Diaphragmatic weakness. C. Recurrent aspiration pneumonia. D. Pulmonary hypertension. The correct answer is B. Diaphragmatic weakness. While not common in mild to moderate Charcot-Marie-Tooth disease, advanced or severe cases can involve the phrenic nerve, leading to diaphragmatic weakness. This results in restrictive lung physiology and can cause nocturnal hypoventilation, particularly during REM sleep when accessory respiratory muscles are least active. Pulmonary function testing showing reduced vital capacity in the supine position is characteristic of diaphragmatic weakness. Thank you for watching our presentation on Charcot-Marie-Tooth disease in children. Remember that early recognition and multidisciplinary management are key to optimizing outcomes. If you found this information helpful, please follow Pediatric Case Review for more educational content. We welcome your questions in the comments section below. Together, we can improve the care of children with this challenging neurological condition.